There are several debates about the role of ultrafiltration rate in continuous renal replacement therapy, and today I will focus on the pros and cons of different rates. I have received grants from Baxter and B. Braun, and these are my only conflict of interest concerns. There are a few things that we know about acute renal replacement therapy in ICU. We know that getting the dose right is important, and this issue has been addressed by two big trials, the renal trial and the ATN trial, and we now have a consensus view about the effluent flow rate to maintain the correct dose. We have data on what is the best anticoagulation to prolong filter life, which was addressed by a nice citrate trial by the ANZIC's clinical trials group. And citrate is clearly the best way of prolonging filter life whenever it can be given. Getting the time right has been addressed by multiple trials, the Akiki, Ideal, and Elaine trial, and more recently, the START AKI trial, and all of them integrated and interpreted together suggest that early intervention is not helpful and waiting for traditional criteria is acceptable. However, getting the volume right has no trials, and we do not have an answer on what is the best way to control volume. Why don't we have volume trials? Is it because intensivists and nephrologists are bad or lazy or they don't care? Or is it that's too difficult to measure volume and create a volume target? Fluid balance may be a reasonable surrogate target for such trial, but what should it be? How would we design a trial? Should be the daily fluid balance, the hourly fluid balance, and then there is the net ultrafiltration rate, which is the fluid removed per hour with a machine. And we don't really know very much about it, and it is possible that it might matter. In order to understand if the net ultrafiltration rate is important, first we need to understand what is current practice. And when we look at the literature, there really isn't very much at all to tell us what is current practice. However, we were able to look at the hourly data of a cohort of more than 300 patients from our institution to see what the fluid balance of patients would be. And you can see that for the first 21 hours, the fluid balance remains positive, and it's only after that that we start achieving a negative fluid balance by means of a significant net ultrafiltration rate. But when we looked at the cumulative fluid balance, which is the result of the ultrafiltration rate and the fluid that's administered to patients, we can see that we only start achieving a negative fluid balance at 48 hours. So that is important for us because we know that a negative fluid balance is really important in terms of decreasing the risk of patients remaining in ICU and having increasing mortality. And you can see here that in the presence of fluid overload, our clinicians clearly choose to have a more negative fluid balance. And also that in patients with lesser body weight, there is a greater probability that a negative fluid balance will be achieved. But how do we compare with other institutions? What happens elsewhere? No one knows because no other studies of this kind have been conducted. And yet we know from the literature that better fluid balance control may be quite important. And the adjusted risk of major adverse kidney events is significantly increased by a more positive fluid balance. However, if we remove fluid too fast, having a very high net ultrafiltration rate, we might also get into trouble. So on the one hand, having a positive fluid balance is a problem. On the other hand, taking fluid off too fast may be a problem. And you can see here that even during continuous renal replacement therapy, a more aggressive ultrafiltration rate is associated with a significant degree of myocardial stunning. Would that kind of stunning, that kind of effect be visible to us? Often not so. The blood pressure may not change, the heart rate may not change, the vasopressor dose might go up a little bit, but then remain steady. And so it is possible that there are these adverse consequences of myocardial function and we are unable to detect them. If they occur, do they matter clinically? Well, the first study to address this issue was published recently in JAMA Open. We used data from the renal trial to investigate whether a net ultrafiltration rate that is high in the top tertile might be associated with greater risk of mortality. And you can see in this table that after dividing the net ultrafiltration rate in three groups, above 1.75, between 1.75 and 1.01, and below 1.01 mils per kilo per hour, we were able to see that the greatest risk of mortality, both adjusted and unadjusted, was present with a high net ultrafiltration rate. And so it appears from association that the middle level of net ultrafiltration rate might be the optimal approach to removing fluid during hemofiltration. This is a graphic representation of the adjusted hazard ratio of mortality when comparing 1.75 to less than 1 mils per kilo per hour of net ultrafiltration rate, when comparing 1.75 to the middle level of 1.01 to 1.75. And you can see that there is a significant difference with increased mortality associated with a high net ultrafiltration rate. And if one looks at the net ultrafiltration as a continuous variable, after adjustment for illness severity, going to higher net ultrafiltration rates is associated with greater mortality. Now, other things happen with a higher net ultrafiltration rate, and one of them is that there is a significant increase in hypophosphatemia. So this kind of intervention leads to more episodes of hypophosphatemia, and so there is a link with another adverse event beyond the mortality, which might explain one of the mechanisms behind the adverse effects associated with a high net ultrafiltration rate. Hypophosphatemia is associated with a variety of adverse events as reported in multiple trials, and higher levels of phosphatemia and a greater intensity of hypophosphatemia increase mortality. One of the important things about any finding is to decide whether it can be replicated by additional studies. So we went and studied our patients. This is a cohort of 347 patients where we had granular hourly data on net ultrafiltration rate to see if, again, the patients with a higher net ultrafiltration rate after adjustment were more likely to die. In this study, we found, which was published in Nephrology, Dialysis and Transplantation, we found that, again, high net ultrafiltration rates above 1.75 were associated with increased mortality. These observations, therefore, confirm the studies published in JAMA and support the view that there is scope for trials that target the optimization of net ultrafiltration rate. So this is important because we got other information that goes back to the role of intensity of solute removal. This is a meta-analysis of all the trials of dose intensity. So this is an IPDMA, individual patient data meta-analysis, showing that high intensity renal replacement therapy shows an effect on delayed recovery of renal function in patients in randomized trials. So given all of these observations that more intensive therapy, more aggressive fluid removal might be a problem, what do people do? So we conducted a survey and we asked people, intensivists and nephrologists around the world, what they do in terms of deciding a net ultrafiltration rate. And you can see from different countries, and to remind you, greater than 1.75 mils is associated with a greater risk of mortality. In an 80-kilogram man, that would be 140 mils per hour. When we ask people what they do, and the net ultrafiltration rate they would deliver on average initially, the maximal rate, the rate they would deliver in hemodynamically unstable patients, you can see that under many circumstances, this speed limit of ultrafiltration rate is broken by clinicians who pursue much higher net ultrafiltration rates than might be safe in these patients. And we ask them what are the factors that regulate the responses. You can see their responses up there, which are clearly related to patient hemodynamic intolerance and dose of vasopressor the patient is on. We also have conducted studies to see if the dose of net ultrafiltration rate also associates with renal recovery. And you can see there that the chance of renal recovery is decreased in the patients that are exposed to a net ultrafiltration rate above 1.75. And you can see that this effect of net ultrafiltration rate on renal recovery plays out at all levels with all sorts of adjustments, and it is significant. And when we do sensitivity analysis using the first 72 hours, looking at periods of treatment, SOFA scores, excluding patients with zero net ultrafiltration rates, looking at patients with a negative fluid balance, looking at different subgroup analysis, this is a constant and persistent finding. A high net ultrafiltration rate is a problem. So let me reflect and finish by saying that patients with critical illness might be in danger because they have capillary leakage, and if they have capillary leakage, they may not have adequate intravascular refill, and thus a net ultrafiltration rate that is high may cause intravascular volume depletion, which may cause organ injury, and a low net ultrafiltration rate, on the other hand, might cause persistent edema. And therefore, a middle level net ultrafiltration rate may be the best. So like tidal volume and high distending pressures and excessive recruitment maneuvers and their associated barotrauma and volutrauma with ventilation, there may be a triad of dialytrauma, which is related to a positive fluid balance, high net ultrafiltration rate, and hypophosphatemia. We need to study this aspect of fluid balance management and net ultrafiltration carefully, and we need to do comparative study to address the issue of dialytrauma.